Okay, I'm going to take advantage of this lull in the room and get things started a minute early today. I want to welcome Andrea Griffiths, who's alumni of our program, so interesting for all of you guys here to hear what she's been up to since she graduated with her MSc. Andrea obtained her Bachelor of Science in Biology from Vancouver Island University in 2000. Following the completion of her BSc, she was awarded a fellowship to study water quality in Belize, Central America. She first became interested in occupational hygiene while working as a research assistant at UBC and commenced her MSc at UBC's School of Occupational and Environmental Hygiene in 2003. Following graduation, she began working as an occupational hygienist at Island Health, where she applied her knowledge and skills to help reduce the risks faced by those working in the healthcare sector. Andrea identified a need to carry out research in the area of cytotoxic drug exposure for those working in pharmacy. She completed her PhD under the direction of Dr. Karen Bartlett in spring 2014. Welcome, Andrea.
Good afternoon, everyone. Thank you, Sarah. So my talk today is about my PhD research and assessment and proposal of controls to reduce cytotoxic drug exposure in pharmacy personnel. So the way in which I've structured my presentation today is based on our kind of principles of occupational and environmental hygiene. So hazard recognition, evaluation, and control. And then the presentation concludes today with some future directions in this area of research. So we're all probably quite familiar with this sort of occupational hygiene model. And so to start off, from a recognition perspective, in terms of cytotoxic drugs, there's more than 100 cytotoxic drugs commonly used to treat cancer and other health conditions. And what a lot of people don't know is that there's a number of possible side effects associated with their use, including immunotoxicity, ototoxicity, cardiotoxicity, and actually, ironically, even cancer. So these drugs that we're utilizing to treat people for cancer can actually cause cancers. So just to give you sort of an idea of some potential either human carcinogens or probable human carcinogens, this is a list put out by IARC. And these are all cytotoxic drugs that are commonly used in a number of treatments in our healthcare setting. And I'll draw your attention to one of the ones down the list, and that's cyclophosphamide. And cyclophosphamide is utilized in many, many treatments. And if you were to look into the literature, what you would see is that many researchers often use cyclophosphamide as a marker of worksite contamination. And so I also, within my own research, utilize cyclophosphamide as a marker of workplace contamination or surface contamination. So I wanted to sort of give you an overview of how these products move throughout the hospital setting. They typically arrive from our manufacturer or your distributor at your stores department in a hospital. And from there, they're transported to the pharmacy department for storage. And then within the pharmacy, they hold these products until they're ready to prepare them. Once they prepare them, they're then transported to the cancer clinic or the nursing unit. And then following that, of course, they're utilized for patient care or treatment. So some examples of potential occupations that are at risk of exposure within healthcare are, of course, our pharmacy personnel. So our pharmacy technicians and our pharmacists, of course. And then beyond the pharmacy, the next, or probably one of our largest populations at risk of exposures are nursing personnel. So those working in oncology departments, and in regular sort of patient treatment and care areas, people working out in home and community care, so they might be providing care to a client out in a home, the person could be on cytotoxic precautions, and then of course in residential care or long-term care. And then we also have our other professionals working in the healthcare setting, so of course the people at the stores who are handling these products that could become damaged during transport. Of course, we have housekeeping that could be at risk as well because there's a number of waste streams where housekeeping is, they are responsible for transporting the waste out of units or departments. They're also responsible for cleaning units and departments that could be contaminated with these products. And then, of course, we have a whole group of other allied health professionals. So those could be people working in medical imaging, laboratories, physiotherapists, respiratory therapists, physical therapists. So lots of people who could potentially be at risk in healthcare of exposure to these drugs. So back to our pharmacy personnel. Within the pharmacy, these are some examples of tasks where people working in the pharmacy could be at risk of exposure. So first of all, receiving department products within the department. A lot of people don't know this, but the products typically arrive from the manufacturer contaminated. There's already cytotoxic drug residue or contamination on the outside of the packaging when they arrive at the site. And of course, the preparation of the drugs for treatments. Our pharmacy technicians are going to prepare those drugs for treatments. And of course, they're going to be handling the drugs in the most concentrated forms. Spill response, that's another one. So in the event of an accidental spill of product within the pharmacy department or outside of the pharmacy department, that could be another area where they could be exposed. And then kind of the final step inside the pharmacy setting could be pharmacists are responsible for checking drugs before they're transported up to nursing units for treatment. So some potential routes of exposure are dermal exposure, inhalation, injection, and also in some other cases could be ingestion as well if the worker were to have hand-to-mouth contamination. And what we do know is that the work surfaces in healthcare settings are contaminated with cytotoxic drugs. And there's been a lot of work done even here on the Lower Mainland by Han that demonstrated many of our surfaces in our hospitals here on the Lower Mainland are contaminated with cytotoxic drugs. And in 2011, Han also published work showing that the drugs could even be recovered from the hands of pharmacy personnel in some of our Lower Mainland hospitals. And typically he saw people working as receivers, and I think it was pharmacists as well, that the drugs were actually detected on their hands. So what we know is that dermal contact is the main source of workplace exposure. And there is evidence in the literature, many publications that have demonstrated that the metabolites of these drugs can be recovered from the urine of the workers that are handling them. And again, back to Chun's work that he completed in 2012 on the Lower Mainland, he actually found metabolites present in the workers' urine. And again, just reminding you that many of these drugs are classified as human carcinogens. So what really needs to be acknowledged is that many changes have taken place since the 1980s to reduce occupational exposure. So kind of before the 1980s, these products were handled on countertops by nurses in units, and there really were limited controls in place to reduce occupational exposure to them. But even though we've made a lot of changes in controls, so we've got engineering controls in place like biological safety cabinets, we've got people wearing personal protective equipment when handling, what we know is that occupational exposure is still occurring. And the long-term health outcome for people that are occupationally exposed is unknown. And from a legal and ethical responsibility, employers really have to protect the health of their workers from exposure to these carcinogens. So just to kind of add a little bit more into the mix about, I just want to talk a little bit about what organizations actually influence practice back in, for those working in pharmacy and healthcare. So all of us are probably quite familiar with Worksite BC regulations, and typically as an occupational hygienist, that's where I look for all my guidance for things when I'm making decisions and finding out more information. So pharmacy needs to work within the bounds of Worksite BC regulation, but sort of compounding that is they have to take into consideration what number of other organizations have to say about working with cytotoxic drugs. And so, for example, United States Pharmacopoeia 797 published a standard which dictates how those working in the pharmacy setting should be handling sterile compounds. And there's also a new standard that's coming out from USP very shortly, and it's called USP 800, and it really specifically speaks to how cytotoxic drugs should be handled. We also have NIOSH to consider. NIOSH has a number of recommendations for working with these products, and they publish a list of hazardous drugs. And then we also have the BC Cancer Agency that comes into play as well. And BC Cancer has a voluntary certification program where they go from worksite to worksite within the province, and they make recommendations as to how those working in pharmacy are handling the products. So pharmacy has to kind of work within the bounds of all of these organizations, and it's actually rather complex. So back to our occupational hygiene model. I'm going to start speaking to the evaluation portion of this model, and that's actually my research. So this is an overview of my research strategy. So I started out with an environmental assessment and just kind of had a look around to see what regulations and so forth were being followed, and then did some looking around for surface contamination. Following this, I did an employee survey. And after this, I did some focus group sessions, and then moved into developing and piloting some safety initiatives based on all the information gathered in the first 3 phases of the study, the evaluative phase of it. And then the study wrapped up with a final worksite assessment. So the environmental assessment. So you'll see on the side of your screen a map of Vancouver Island, and there were 7 work sites that I initially identified that were, to my knowledge, handling cytotoxic drugs. And so initially I went into the work sites and I gathered information on how the pharmacies were configured and what control strategies were in place, and how to look to see as to whether or not regulations and standards were being followed. And so that's kind of like in our occupational hygiene world, that's kind of known as our walkthrough. And then what I identified through that is that there were actually a couple of the work sites, 2 of the work sites, that either didn't handle the drugs as frequently as I thought. They usually either handled them not at all during the year, or perhaps maybe once a year, or on very rare occasions. So I narrowed my focus down to 5 work sites, and I returned to them, and then I did some surface sampling to look for the presence of 2 markers of contamination, methotrexate and cyclophosphamide. So that's not to say there's not a number of other products on the work site, on the work surfaces, but these are the 2 that I decided to assay for. So what did I find? Basically, what I found is that surface contamination was present at all of the work sites, and the contamination was independent of where the work site was located, whether or not they had controls in place, such as an anteroom, the presence of a clean air bench, the presence of a training program, and who was providing the housekeeping. And there were a number of different layouts and designs and controls in place. And work sites as a whole did not and were unable to meet work safety regulations and all the standards from other organizations. So I'll just show you an image of a few different work sites here, and just to kind of walk you through. The one on the top left-hand corner is an example of a pharmacy where the picture is taken from inside the mixing room, and what you can see is that the door is open to the rest of the pharmacy, so there's no anteroom and so forth. And so that's one work site. And then the one on the right-hand side, the larger image, is actually a photo that I took from the hallway of a hospital, and it actually has a service window that was open to the mixing room. So even though you can't peek behind the door, if you were to look behind the door, on the left you'd see a pharmacist going about his or her duties, and to the right you would see a pharmacy technician preparing these hazardous drugs right in the same room. And then on the bottom left-hand corner, there's an image of an anteroom, which was in a very, very tiny site that seldom or never handled the drugs, but it had all the proper controls in place, had a beautiful pass-through and so forth, and it was very, very well done. So the next image I just want to show you is, this is an image or a schematic of an ideal setup for the flow of cytotoxic drugs. And this particular one, the drugs actually flow in sort of a one-way direction. They're all stored here on the right-hand side, and they're staged in this area, and then they're put into a pass-through. And then the pharmacy technician would enter the anteroom and don his or her personal protective equipment. And then they would prepare them in the room and then pass them out to the pharmacist through another pass-through where they're checked prior to going out to the unit or department. So this is the best setup you can possibly get. It follows all the standards, all the regulations. It's absolutely amazing. And what I found is that cyclophosphamide could be detected above the limit of detection in the room where the products were stored. So beside the sink, on the doorknob inside the room where the pharmacy technician is preparing the products, on the seat where the technician sits, and then in the transport box where the pharmacist would place the product before it goes up to the unit or department. So it was great to have all this information, and really it told the story about what was going on in the workplace environment. And this was all good to know, but I really wanted to know, I mean, if everything was kind of in a perfect world as a hygienist, I would say, the setup, the work site that had the perfect setup had the least amount of contamination, and they didn't have any contamination at all, lower levels of contamination. But this wasn't the story. As I said earlier, there were no differences amongst work sites for work site contamination. And so I really wanted to find out what was going on with people at the work site level within the organization and at the individual level. And that's how I kind of led into the employee questionnaire. So employee questionnaires are a really great tool that health and safety professionals can use. And they're used to sort of provide and gather information about the current state of a safety program. And they provide a baseline. They're inexpensive, they're straightforward, and they're really good because you can start to gain insight into the practices of this group of workers. And so I distributed 130 employee questionnaires at the 5 work sites where I had done the wipe test. And I had questions on general information, what I think and know about working with cytotoxic drugs, how they were utilizing personal protective equipment during the preparation process, and then questions on training and education. So what I found is that the population was predominantly female, and those that participated the majority were pharmacy technicians at 66%, and 34% were pharmacists. The largest age category was between 40 and 49 years of age, and on average they had about 16 years of experience, ranging anywhere from 3 months of experience all the way up to 40 years of age. And they reported out a number of tasks they were involved in. So 58% involved in preparation, a quarter of them in receiving, and 27% in checking. So the receiving would be the pharmacy technicians, and of course the checking of products most likely to be the pharmacists. And what was surprising about this particular result was that only a quarter of participants involved being with spill cleanup, and that was actually quite surprising because one would think if you were involved in the use or handling of these drugs that everybody who participated would have reported out some knowledge or role in spill cleanup at the site. So when considering the equipment worn during preparation, there's an image of somebody on the right-hand side who's kind of wearing all the personal protective equipment required for handling these drugs or recommended for handling these drugs. So that includes head cover, an impermeable gown, shoe covers, gloves, scrubs, and some sort of respiratory protection. What the results showed was that 76% of participants indicated wearing hair cover during preparation. And one of the biggest differences was in terms of respiratory protection. So 61% reported wearing a surgical mask, and 24% reported wearing an N95 respirator. So an N95 respirator will protect the end user and the product, whereas a surgical mask is more likely to just protect the product. So that was a big difference. Also, the use of shoe covers was only reported out in 29% of work sites. And shoe covers are intended to prevent contamination from going into the mixing room, so keeping the product safe. But actually what we know from the literature is there's a lot of product on the floor in the mixing room. So if people aren't wearing shoe covers, there's a large possibility that they're going to be trekking around the work site in the pharmacy with those products on the bottom of their shoes. So there were some differences in responses to the questions. First of all, when stratified by level of education, bachelor versus certificate. So in this case, it actually acts as a surrogate for pharmacists, being the ones with a bachelor's degree, and technicians being those with the certificate. And when there was a question posed to participants on their ability to protect themselves during a leak or spill of cytotoxic drugs, there was a difference in responses between these two groups, whereby pharmacy technicians responded more favorably to the question compared to pharmacists. And then there was also a question posed on the risk of exposure in their current position to the products. And in this case, it was pharmacy technicians that responded less favorably compared to pharmacists. So that's likely because the pharmacy technicians feel they're more at risk because they're typically handling the products more frequently than a pharmacist. And then when the data was stratified by worksite location, there was a question posed about training. And the question was basically, was the training received to date adequate to protect themselves? And those work sites that had an in-house training program responded more favorably compared to those that did not. So this was all good information, but I really wanted to learn more about the workforce and engage them in further dialogue because I really wanted to find out what their ideas were on working with these products and how we can make things better for them, find out if there were barriers to them working safely with them. So my whole aim of the focus groups was to gain insight from them and figure out how information that they could provide could be factored into strategies that would ultimately reduce their potential for occupational exposure. So the way in which I structured the focus groups is they were held at those 5 work sites where I did the white test, and there were 4 to 6 participants in every session, and they were about 2 hours in duration. And I started every focus group asking them what were their thoughts on working with cytotoxic drugs. And then I would share with them the results from their environmental assessment and their employee questionnaire and get some feedback on that. And then I asked them whether or not they felt there were barriers to working with the product safely. And also at the conclusion of every session or before the session ended, I wanted to get their insight as to what they thought some potential future directions could be for working safely with these drugs. So there was a lot of information that came forth from these sessions, so I'm just going to kind of point out a few highlights on them. On kind of the very first question, what are your thoughts on working with cytotoxic drugs? From a personal health perspective, a lot of them expressed concerns, or many of the focus groups, I heard concerns about past handling practices, because in the past people weren't quite so stringent when they were, and careful when they were handling the products, so people were concerned about their long-term health outcomes. One of them that was a little bit of a surprise to me was many of the participants talked about, or at least in 2 of the 5 focus groups, spoke of how there was a risk of musculoskeletal injuries from handling the drugs. So pharmacy technicians typically sit at a biological safety cabinet for a long period of time preparing these drugs. So a lot of them had experienced musculoskeletal injuries as a result of this. Another interesting one was many of them pointed out, or 2 of the focus group sessions out of the 5 pointed out that there was an absence of a health monitoring program. So the employer has no programming in place to determine whether or not there's any changes in people's health that are handling these drugs. Another thematic category was safety in the workplace. So interestingly, this was before I showed them any of the results from their white test, many of them felt that their current practices in place were protective against exposure. And another interesting idea that came up is that many of them had brought forward the idea that individual practices varied pertaining to working with cytotoxic drugs. So for example, one person might follow one safe work procedure in their work site, and somebody else might follow another one. So on the question of, are there barriers to working safely with the drugs? One of the thematic categories was limited time and resources. So many of them talked about how heavy workload and limited time would prevent them from working safely with the drugs, how changes in resourcing and availability of funding could prevent them from working safely. And then, of course, one that's probably not surprising is given that we had a number of different physical layouts and designs, people felt that the physical space and the design of the work site itself actually prevented them from working safely. And another one that was kind of a little bit interesting to me was relationships between healthcare providers. People talked about how their relationship with pharmacy versus those working in oncology could have a bearing on how they could work safely. And then, of course, interpersonal sort of relationships inside the pharmacy setting as well. So when I was moving forward and kind of wrapping up each of the focus groups, I really want to know again, what were some ideas for strategies that we could use for working safely with the drugs? So one of them was, of course, standardizing protocols and policies. So making sure that across the organization, everybody is utilizing the same safe work procedure and everything is consistent. Another one was standardized training and education. So ensuring that everybody who's oriented and everybody who comes through the door has the same messaging when they start the job. And also standardized training for spill response and cleanup as well. And the last one was increased supervision. And this one was really interesting to me because I'm not sure what that would look like as a safety initiative, because there was a lot of participants that kind of felt that they were looking for increased supervision so that the supervisor would ensure that everybody was following the safe work procedures. So I thought that one was quite interesting. So the next phase of the study, moving into the control aspect, and that was piloting out some of these safety initiatives. And so basically, determining which initiatives that could be included for piloting was based on the three evaluative phases of the research. And so some of the criteria was that they had to have been identified in the previous phase of research. And of course, we really had to take into consideration what impact it would have on worksite resources. So as much as I wanted to build new pharmacies, I really didn't have the funds or the ability to do such a thing. Another thing is that the initiative had to in some way contribute to meeting one of those standards like USP 797 or to meeting work safety regulation, or to better meeting them, I should say. And so the safety initiatives that were selected were coming up with a standard procedure for receiving the product in the department, a standardized spill response protocol and with some training to go along with it, a safe work procedure for checking the product, and then finally a new employee orientation, a standard one. And every initiative was to be evaluated by participants. So I had 4 key questions with a Likert scale on the evaluation. So questions such as, was the information applicable to them in their job? Did it increase their knowledge on working safely with the products? Would they actually be able to use the information during the course of their duties? And would the information help to reduce their potential exposure to the drugs? And then I had 2 open fields on the questionnaires, and one of them said what I liked about this initiative, and then the other field was what would I do differently with this particular initiative. So the very first one was the protocol for receiving the product, and this one received very limited feedback. And I have to acknowledge that there are really a limited number of personnel within the organization that are responsible for receiving the drugs inside the pharmacy department. And some of the feedback that I got was that it was great, and this is again, the questions were good to have with the Likert scale. They were great, but what was really telling was the open fields that allowed the participants to put in more information. And so, yeah, they thought it was great. Lots of straightforward, easy to read, but what was really interesting is they didn't agree with the personal protective equipment that was recommended for use. And so what this tells me is that they may be unaware that there is actually a risk to them when handling the product. Or alternatively, it could be possible barriers to the use of personal protective equipment. So perhaps the personal protective equipment is not available, or they don't see other people around them utilizing personal protective equipment. The second initiative was the spill response training. So I developed a 1-page protocol, and then the way it worked is I would go to the site and we would do a mock spill cleanup, and they would utilize the protocol and walk through the process. So this received the most feedback of all the initiatives, and what I started to see was that there was some really positive feedback from this one. People felt more confident or expressed the new confidence in sort of their ability to clean up spills, and they thought it was great because spills don't happen that often, but they had a sense of how they could handle a spill if one were to occur. And the protocol for checking products. So this is the protocol that we would ideally want pharmacists to follow. And I actually did the design in conjunction with a pharmacist. And again, it was kind of similar feedback to the receiving protocol in that pharmacists thought it was great, good for them to know, but they actually did not seem aware that they were potentially at risk for exposure to the drugs during the checking process. So a lot of them felt that because the technician put it in a bag in the biological safety cabinet and passed it out, they were not likely to be exposed. However, what we know is probably the product's on the gloves of the hands of the pharmacy technician, and then they touch the outside of the bag, and then it goes out through the pass-through. And my white test showed that, of course, there was cytotoxic drug contamination in the transport box. So it's most likely that they were unaware that it could even have the residue or get the residue on their hands. And the final initiative was the piloting of the new employee orientation. And the way in which the presentation was structured was that it had 2 key themes, and it was basically what do you need to know and what do you need to do when working with these products. And so on this graph, you'll see there are the 4 key questions that I asked the participants in the evaluation. And on the first question, basically, was the information on cytotoxic or hazardous drugs applicable to them in their job? And what I should say is I actually piloted this out on both new and existing employees. And so Basically, new employees, for the most part, either agreed or strongly agreed with this, with the exception there was about 17% that were neutral on this particular question. And that's most likely because they're not actually clear on what their role will be in the department. They may not even be involved in handling cytotoxic drugs. Did the information presented, or did it increase their knowledge on working safely with the products? All new employees either agreed or strongly agreed. Would they be able to use the information during their duties at work? And again, kind of back to that similar sort of result with the first question, the new employees, a third of them said they were kind of neutral in this particular question, because again, they may not know what they will be up to. They might just be compounding sterile products. They may have no involvement in handling cytotoxic drugs. And then the last question, would the use of the information help to reduce their potential exposure to the drugs? So nearly all new employees either agreed or strongly agreed on this particular one, whereas there was about 18% of existing employees were neutral on this particular question. So the final worksite assessments. So I went back to all of the worksites about 6 months after I had completed the safety initiatives or piloted them. And I used a similar approach that I had initially used in the first phase of the study. But I started to narrow in on what was actually in place to reduce staff exposure to cytotoxic drugs. So I focused in on safe work procedures and their use of personal protective equipment. And what I found is that there were some changes in the presence of controls to reduce cytotoxic drug exposure. So for example, I saw an increase in the presence of written safe work procedures. So for example, initially only 40% of work sites had the protocol in place for cleaning up the spills. All of the work sites had it in place at the conclusion of the study. I can't say that if I go back now it'll still be there, but at the conclusion of the study it was there. Personal protective equipment, what we know is that 40% of the work sites had N95 respirators in the beginning available for employees to use when they're handling the drugs or when they're preparing the drugs, and that increased to 80% in the end. And then the use of elastomeric respirators, or the presence of elastomeric respirators. In the beginning, only 40% of the work sites had them available for personnel to clean up a spill, and at the end, they were available at all of the work sites. So some future directions. Inside the hospital setting, we need to really work towards formalizing the implementation of these protocols that were piloted and some training. But before we do that, I think we need to do a little bit more work in understanding our workforce, because judging from the feedback on piloting those safety initiatives, not everyone is clear that they're actually at risk of exposure. So probably we need to do some risk communication work with this group and find out a little bit more about what they're thinking and so forth. And what are their barriers, again, to following safe work procedures and practices. We need to kind of explore the use of some more engineering controls or additional devices beyond the biological safety cabinet, which is typically used for handling the drugs. There's a lot of products out nowadays that are closed system transfer devices that can be utilized inside the biological safety cabinet, and that might be an effective means to reduce exposure. Definitely a need to standardize the use of personal protective equipment. And also some further engagement of leadership to facilitate a culture of safety. Outside of the pharmacy setting, the work has already begun for me as a practicing occupational hygienist, but working with others involved in the handling of these drugs. So for example, focusing in on healthcare, the housekeeping personnel. So for example, do housekeeping personnel know how to properly clean a room where the products are prepared? Do they know how to properly dispose of the waste and protecting themselves? And those working in stores as well, do they know what to do when cytotoxic drugs arrive that could be damaged? Those who transport the products as well, and those working out in home and community care. So those that are caring for clients out in the community that could be under cytotoxic drug precautions, because many people might go into a BC Cancer Center or one of our local work sites and undergo chemotherapy, and then they're back in their homes. So we need to ensure that those working in home and community care are properly prepared and able to care for them safely, because they need to deal with things like bathing them and waste disposal and that kind of thing, and patient handling or resident handling. And then, of course, those working in residential care. So people that are working in long-term care facilities and so forth, because some of their residents may actually be treated with cytotoxic drugs. So for example, they might be treated with something like methotrexate for their arthritis or so forth. So they really need to know how to properly care for them safely. And that's him. So thank you so much.
Thank you very much, Andrea. Just a reminder to anybody in the room that you need the mic if you want to ask a question. And are there any questions?
Hi. Just a question on the slide where you showed the stats, the analysis on the degree versus the certification.
Mm-hmm.
Did you say that the certification was, the people with certification were better
It depends
at understanding?
it depends on the question. So with respect to spill response, those with a certificate, so the pharmacy technicians, felt more confident in their ability to protect themselves during a leak or spill of the product compared to those with a bachelor's, so a pharmacist. And that's most likely because pharmacists may not have had the hands-on practical thing in school as to how to clean up a spill safely, or they may not feel that they're directly involved in it. They may think that it's the responsibility of the technician to clean up a spill. And so, yeah, so that was one of the big differences there.
Oh, interesting. Thank you.
Great presentation, Andrea. So near the end, when you were talking about the future directions, for at least inside the hospital setting, you brought up closed system transfer devices.
Mm-hmm.
And so, I mean, I've read about these, but I haven't really talked to many healthcare workers about how they feel. So I was wondering, I mean, how realistic is that as a future movement? How do healthcare workers feel? Is it a huge financial barrier? Things like that.
Yeah, those are all really good questions, and we're actually kind of working through that process right now. My understanding is that the BC Cancer Agency has already implemented these devices in their sites, and from what I understand, there is a lot of training that goes along with becoming familiar with those devices. And you're absolutely right, cost is another thing, because right now we have the product in a lyophilized form, and it's a vial in there, and the technician adds water directly to it, and then they spike their bag, and away it goes. And with these closed system transfer devices, I'm not clear on what the cost implication is going to be at the site level, and what the actual outcome, how effective will it actually be at reducing contamination. And I'm in the process right now myself of learning more about that. And so I'm going to be speaking more with BC Cancer and finding out some potential barriers that they've faced in the implementation of those, and kind of what the benefits are. And I think in my calendar right now, I'm supposed to be booking with a sales representative who is responsible for these particular products. So yeah, it is quite interesting. I'll be curious to see and learn more about them.
Great presentation. So you mentioned that USP 800 is going to be coming up soon.
Yeah, it is.
Yeah. So what are the differences, and are there any differences that will impact your safety, the safety in pharmacies?
And that's a really good question, Karen. And it's quite complex because, again, USP 800 is best practice, but it's not enforceable by any means. And some of the key differences between USP 797, because USP 797 just kind of directly addresses sterile compounding as a whole, and USP 800 narrows down to hazardous drugs in particular. And what I saw is that I was pleased to see that a lot of the recommendations in USP 800 are it's still in draft form. It's available up online, and people can read it if nobody would want to probably read it in here. But it was interesting to me because the personal protective equipment is far more stringent than ever anticipated. They're recommending an N95 for mixing the drugs, and they are recommending that an elastomeric respirator is utilized for decontamination of the biological safety cabinet and for spill cleanup. And they'd like to see, I'm not sure if you guys are familiar or not, they'd like to see that the respirator cartridge on the end is actually a Defender cartridge, so the P100 coupled with an organic vapor cartridge. So I was quite pleased to see that because that was one of my recommendations, and people were a little bit hesitant, and there was quite a bit of pushback because people wanted to kind of stick with the N95 for spill cleanup or a P100, and citing that it probably was a little or no risk with the compound cleaning up. And so I was pushing to have the organic vapor cartridge as well included in the spill cleanup kind of mix. So yeah, it's going to be very interesting because I think that they've had a lot of feedback, and I'll be curious to see what the actual final draft of USP 800 looks like.
Great. Good work on getting the elastomeric respirators more widely used. I hope that
well, we know they're there. Now, whether or not they're using them, that's a different question. But yeah, absolutely, okay. They are present at the work site. So again, some more work needs to be done to find out if people are indeed using them.
Yes, exactly. It'll be it's something I've addressed with a lot of people in a lot of places over the years, getting them to use an elastomeric respirator and find out whether it fits or not.
Mm-hmm.
And yeah, first thing is to make sure they wear them right side up.
Yeah, that's always key.
I've got a few people wearing them upside down. Anyway, the question I have is, how big a source of exposure is the patient that's had these drugs administered? Is their sweat contaminated?
Yeah, absolutely, yeah. And that is a very good question because, yeah, their sweat is contaminated. Of course, all their blood or body fluids are contaminated. So again, they've actually even recovered the drugs from the water after bathing patients. There was a study done in residential care, and post-bathing, they sampled the water in the washcloths, and they were indeed contaminated with the drugs.
How about their exhaled breath?
I don't know about that one, but yeah, I would imagine their exhaled breath could potentially, depending on how the drug is metabolized.
Yeah, that's no good. Yeah.
Okay, a couple of questions from our online audience. First, is there a difference between a cytotoxic drug and a antineoplastic drug?
Yes, an antineoplastic drug they could be one and the same, but cytotoxic has sort of one definition as it is, of course, toxic to cells, and antineoplastic is sort of more specifically geared at cancer treatments.
All right, and then there's a question here that I don't even understand, but you might. It says, I've noticed that microfiber blankets are used by PT during treatment. Was this checked as a source of contamination, and does laundering remove it? The question of whether these should be laundered separately then arises.
Oh yes, laundering. That is always a key question. I did not test any materials per se, just surfaces to look for contamination. And could PT have a blanket that's contaminated with cytotoxic drugs if the patient was sweating or some of their blood or body fluids got on it, of course. And at the provincial level right now, what we're working towards is having a laundry bag that just kind of identifies or separates or segregates out laundry that's contaminated with cytotoxic drugs or potentially contaminated. So trying to stream the laundry in a particular way. So that's still in progress.
Hello.
Hi.
Hi. 2 questions.
Sure.
First one, I was wondering, it would seem to me, in my thinking, maybe I'm wrong, pharmacy employees, are they at higher risk of exposure to cytotoxic drugs than the nurses?
That's a really good question. I don't know. I think that there's a number of groups that are at risk of exposure. Pharmacy is handling it in the most concentrated form, but they also have kind of a more stringent engineering controls in place to protect them from exposure. And so it really would depend on the volume of drugs that they're handling and how frequently they handle it and so forth. And that would say, like, if you were to kind of look at them versus the nursing population. And again, it would depend on how frequently the nurse is caring for the patient and what sort of tasks is he or she involved in, whether it's administration of the drug or if it's just patient care. So it really would depend on how frequently they handle them and in what manner they're handling them.
Okay. Second question. You said all you said about the levels that you detected was that you detected them above the level, the limit of detection. But how much higher than the LOD are they? The other thing I was wondering is, can you just comment a little bit on the levels in different areas? Which area of the pharmacy is at higher risk? Which personnel, which employee, you know?
Well, it's interesting because if I think about, I don't know the values in nanograms per centimeter square, definitely off the top of my head, but I can tell you objects like, for example, within the biological safety cabinet, a marking pen came back at one of the sites as one of the most contaminated objects ever, and in my data. And but who's at risk? You know, are they at risk? because if you're sitting at the biological safety cabinet and you're wearing your gloves and so forth, you know, is the person at risk of exposure if they're wearing the proper personal protective equipment and changing out their gloves and so forth. So yeah, biological safety cabinet, super high, like with the pen, you know, or on the chair it might have been high as well because perhaps the drug got on the person's hand and they touched the chair. So yeah, there's like a lot of kind of variability. But there's no, I can't say that there's one area that is more risky than the other in the pharmacy, but certainly the mixing room would have the highest likelihood of contamination compared to other areas of the pharmacy.
I'm going to ask a question. This seeming conviction that personal protective equipment was a step too far, is that a common finding in this type of work, and what do you do about it?
I'm not sure quite what to do about it, but I think, again, it's going to have to go back to employee engagement and finding out why they think that. You know, like what are their values and attitudes and beliefs, and is there support at the organizational level for them to utilize personal protective equipment when they're handling these products? And I mean, in other industries, like you think about the chemical industry, there are lots of literature that basically says people are reluctant to wear personal protective equipment. They don't want to wear it. It's uncomfortable. It's inconvenient and so forth. And sometimes people would rather take the risk of potential exposure than don the personal protective equipment.
I just wanted to add a point. A question Ed was talking about earlier about the metabolites or CP showing up in exhaled breath. I can't say I've seen any studies specifically addressing that. But I have read one study that took airborne samples in the Czech Republic about 2011, where the only positive samples they found were in the outpatient clinic, as compared to the pharmacy, the shipping areas and such. So I mean, that's something to think about. It's not known how the drug was getting in the airborne form.
Yeah, and it could be during the
breath.
administration route, right?
That's
As
true.
well, if something's being aerosolized off of a line, if it's a volatile compound, it could be coming off. Yeah, or you're right. Could it be exhaled patient breath?
We don't know yet.
Yeah. It would also depend, I guess, on the route of administration as well, because typically it's IV, so I don't know that we'd see exhaled breath quite that quickly as well, because it's not an inhalable sort of route of delivery.
Yeah. Do any of the, have any of the people you've talked to mentioned short-term symptoms they experience after working with these drugs?
When I look back through our database, like historically, to look for exposures, that was one of the things I really looked at. I was curious about how many people actually reported out acute ones. Typically, what I've seen is that if somebody had a spill on their hands or an exposure, it was dermatitis that they'd experienced right away.
And that would be if they had a spill when they weren't wearing gloves or when they were wearing gloves?
Sometimes it was actually even handling urine. You know, somebody gets the urine splash on their wrist or something like that when they're dumping a commode or anything like that when someone's on precautions. There was actually a person that reported it out. It happened repeatedly, and before they kind of made the connection that that's actually what was going on, because you know people don't always necessarily wear gloves when they're dumping urine.
And this is people that have been treated have the urine contaminated
Yes,
with the drugs.
exactly.
Thanks, Andrea. What about risk management plans for housekeeping staff and other nursing personnel with all the talk about patient blankets and laundry?
What is the plan, or what is the
just risk management protocol?
I'd have to say that it's going to be different site by site, and what really complicates matters is that within the organization I work, some of the housekeeping is contracted, and there might even be multiple contractors on site that do housekeeping. And then we have in-house housekeeping. So actually there's a lot of dialogue right now going on, again, about consistent processes and so forth, and how do we manage that. And at the provincial level, we have a cytotoxic drug working group with a number of occupational hygienists on various health authorities. And we've recently come out with a draft of an exposure control plan that will be consistent across all health authorities. And one of the protocols within there is housekeeping, and really sort of speaking to, you know, what are the typical tasks they could be doing, and what personal protective equipment and what measures should they be taking to protect themselves, and preventing contamination from getting tracked around the site as well. Yeah, and that's going to have to be a component of it as well. And again, but how this is again, it's really challenging because it almost has to be written in the contract with the service provider and who provides the education and so forth, and how often is it provided, and it's very complex.
Hi there, thank you. I was wondering, what are the levels of the negative health effects associated with cyclophosphamide exposure, like in hospitals in BC? Are people becoming ill because of exposure?
Well, good question. And again, the long-term health impact is unknown, and there are no studies right now that would demonstrate that because, again, there would probably be a lag time. We don't know what the long-term health outcome is from chronic low-level exposure. There has been a few studies that have come out recently that kind of speak to changes at the cellular level based on long-term exposure. And but in British Columbia, there is no data to date that would show us that. And again, it would be very difficult to go back and find out that information. But that is actually a question that when I was doing the focus groups, a lot of the pharmacy technicians and pharmacists really wondered, you know, is there studies about health and long-term outcomes? And I didn't have anything specifically for pharmacy to share with them, unfortunately.
All right, if there's no further questions, another round of applause for Andrea, please. It was fantastic.